taking time out to come to this conference. We promised the last time we did the conference earlier in the year that we would have a follow-up conference, and we were hoping to have had it at the L&D hospital, but unfortunately that wasn't possible on this occasion. But the purpose of this conference really was to follow up some of the issues and some of the points that were raised from the previous conference with regards to what is Luton doing following the David Bennett inquiry. Before I go further, I should have done it before, but just like to introduce myself. My name is Trevor Adams, Pastor Trevor Adams, from the Family and Relationship Crisis Centre. We are the umbrella organisation, the parent organisation that runs Dignity Mental Health Advocacy. Dignity started about 3 years ago in response to the local African Caribbean community, identifying that we needed to have a culturally competent advocacy service. There was a mental health advocacy service for the African Caribbean community. The difference being was that it wasn't run by the community from within the community. And we were approached by social services and a primary care trust at that particular time to set up the mental health mental health project. And we chose to call it Dignity because, as most people are well aware of, is that mental health is one of the key things that can automatically rob a person of their dignity. And we set up to set up a service that respects the rights and dignity of those that we come in contact with who, for whatever reason, find themselves having a mental health problem. So basically that is a bit about the background to Dignity. The original conference was to highlight the fact that following the David Bennett inquiry, the importance of all the services responding and taking into account the needs of the African and Caribbean community. And of course, being an advocacy service, we felt that we owed a duty, a responsibility to actually raise our concerns in partnership with all the various statutory agencies in Luton, to actually sort of say, well, what are you doing in response to the David Bennett inquiry? And if you bear with me a moment, I would just like to run through what some of the recommendations were from the inquiry. At the last conference, we were quite fortunate to have Dr. Joanne Bennett, who was the sister of David Bennett, who spoke quite passionately about her family, their upbringing, and some of the challenges being an African Caribbean community and having somebody within the family with a mental health problem, and also having to deal with not having sufficient knowledge and information at the time and not having the support necessary to respond to that particular situation. But following the death of David Bennett in care, there were a number of recommendations that were made. And one recommendation that was made was the need for cultural awareness training. And the thing that Dr. Bennett said, it wasn't the fact that we needed to be treated differently, but the fact that we needed to be looked at as individuals with specific needs, and the service needed to be responsive to the needs of the individual. And an example that she gave was that, not everybody eats rice and peas. So you should make the assumption that because somebody is from the Caribbean, that necessary cultural competence is about providing rice and peas. Okay? I'm from Guyana, South America, And some people would say it's the Caribbean. I would argue about that and would say, well, Guyana's never ever been in the Caribbean, it's in South America. Okay, and she actually highlighted the need for the services to be responsive to individual needs. That the need to have, agencies need to have a written policy dealing with racist abuse. And not just have a policy, but to have something in place to actually address racial abuse. And also the importance of ensuring that there is ethnicity data, and not only about a person's ethnic origin, but also about a person's faith and how faith plays a part in terms of a person's well-being. Also as well, that there need to be in place training policies whereby staff receive training in the assessment of the black minority ethnic population with regards to the effects of racism. How does racism affect the black community? How does it affect a person with a mental health problem? Also, that all patients are entitled to a second opinion from a doctor of their choice. These are some of the things that the recommendation threw up. And also a challenge to the Department of Health that they should modify the benefit system so that patients do not leave hospital in order to access more benefits. All patients and their families should be aware that patients can apply to move from one hospital to another. One of the things that Dr. Bennett actually highlighted was the sense of disempowerment that comes to a family who aren't aware of what their rights are, who aren't aware of what the support structures are in place. Again, staff need to be trained in the importance of not over-medicating patients. Those were some of the recommendations that the Bennett inquiry raised. And basically the first conference was about calling all the different agencies, calling all the statutory agencies together, and basically asking the question, in light of the David Bennett's inquiry, what is actually happening within your agency, what is actually happening in Luton, based on these particular recommendations. It wasn't, the idea of conference wasn't to be confrontational, it was to say how can we, in partnership, address the needs of a vulnerable community here in Luton. And this conference basically was for us to come together and basically say that in light of the recommendation, in light of agencies looking at the recommendation, what has happened in Luton 6 months on. So that was one of the reasons for this particular follow-up conference. So through the day, you will hear from different speakers from different organizations actually highlighting what it is that their particular organization have been doing 6 months since the last conference, or if they weren't able to attend the last conference, what is it that they have been doing. We had wanted Dr. Bennett to have come back and to perhaps share with us what's been happening in terms of the bigger picture and her work with the Circle Affair. But unfortunately, she's not able to make it, but she should be sending a representative from her organization just to update us. And I just really want to thank all the different organizations who have been working with us to actually put on this conference, and I'm going to be thanking you again. Okay, but just really want to acknowledge that it wasn't just dignity, but it's an actual partnership of organizations working together to raise and highlight these issues. Can I ask, if you've got your mobile phone on, could you put it on stun? Okay, so when it goes off, you'll know your phone is on. Okay, can you switch off your mobile phone, please? There will be opportunity throughout the day for you to ask any questions. And there's a young lady there, Emma. Emma, could you Senna. If you've got any questions that I can't answer, okay, then I'm going to point you to Emma. Emma is the project manager for Dignity Advocacy Service. So without further ado, I'd just like to call on our first speaker, and it's Faye Brown from Bedfordshire and Luton Community Trust. And I just really need to get the mic is there for you to use.
No, I can shout.
You've got a big voice like
I've got a big voice, yes.
Okay. Did you want to open?
Okay. My name is Faye Brown. I work for the Bedfordshire and Luton Community NHS Trust as a project manager in developing and implementing the new model of care for working age adult mental health services. I work in partnership with both Luton Social Services and Bedfordshire Social Services and the 3 primary care trusts. So in terms of actually sort of delivering a new model of care. I think you've got some details about my background. I've worked in mental health services for around about 12 years in a range of different guises, both in, I used to work for the NHS and then I swapped sides, if you like, and then became a social worker and worked in social services. And now I'm working across both, so different perspectives around all really. So, what I'm here to talk about today really is we've been working with the Health and Social Care Advisory Service in developing a new model of care for adult working age mental health services. This has been going on around about 2 years now and involves, this is shaping our mental health services for the future. So we look at why did we actually need to sort of go ahead and do this really? Well, the first point of course is what's driving all of our policies has been the service user needs. And service users over the last 10 to 15 years have actually been quite rightly talking very much about mental health services and how they've actually traditionally not met the needs. I think it goes back to one of my points that my colleague earlier was saying. And it's about how politically there's been a recognition that there's been some changing. And then likewise, there's obviously a lot of carers out there who've been supporting people with mental health problems in their own homes for years without getting the support that they need. So it's all these sort of positions and views coming forward and actually influencing policy. Partnership working. Well, as probably most of you will know, by April next year we will be a partnership trust. And that involves both Luton Social Services and Bedfordshire Social Services integrating with Bedfordshire and Luton Community NHS Trust. And part of that very much is around ensuring that services that are delivered actually meet needs in a joined up way. Because one of the things, again, that recommendation after recommendation talks about is these services are not joined up. Yeah, if you need to get, I don't know, a particular resource for respite care, you have to go to a certain agency. If you need a medical care, you go to a different agency. Very much around trying to join up the services so one person has a holistic, their needs met in a holistic manner. And of course then we've got the National Service Framework for Mental Health, which is the political drive and the policy that tells us very clearly how we need to be shaping our services to meet needs in the future. And of course the NHS plan, which is another sort of policy driver around that. Okay, and I go back to the point around that the underpinning principles when we're developing the model of care is that to ensure that the needs of the users and carers are at the very centre of our development and of our delivery. And part of that is actually involving, and I've done a lot of work around trying to involve users and carers in developing our new services. And that's around, what are your experiences? How do you need to do it different? How can we change this? Meeting local needs. Now one of the things is we have a model of care which I'll show you in a moment, but it's also ensuring that we have a policy that stretches, so people living in Bedford, for example, and people in Luton get a similar service. But actually there are local differences, and it's about challenging and checking out what those differences are and how we need to sort of shape our services to meet those differences. Principle of recovery. I don't know whether you've actually heard about recovery. Recovery seems to be becoming a really sort of a new way of thinking about mental health matters. It came from America around about 5 years ago, and it challenges us to actually change our attitudes, both in a society and in the services, about how we think about people who experience mental health problems. And that's around starting at the point where people can and do recover from mental illness. And it's really around challenging that assumption wherever we go, and actually ensuring that we can meet people's needs with that optimism. You will recover from this. There are other ways of doing it. You know, so it's that sort of principle that we're working on. It's very much linked to the social inclusion agenda as well. So it's very much around meeting people's needs in the community, not in traditional statutory sort of bodies, really, if you like. And again, the other principle is valuing diversity and inclusion. It's valuing difference. I'll go talk a bit around that. That it goes back again to what my colleague here was saying. It's actually looking at people individually, because all of us are different, and it's around checking out when we're actually assessing somebody, is what are your needs individually, where do you live, what do you want to do, how do you want to do this differently. So it's trying to step back from traditional ways of mental health services. And of course the social inclusion agenda is around, it's challenging all services to think differently around what services we might offer and where particularly we might offer them into. It's actually much more around going out into the community rather than actually in a traditional sort of hospital base or team bases or wherever. I think I mentioned that point, that joined up at the point of delivery, that goes back. Model of care, now that's not a great picture, but I do have some bigger ones here. Because it is actually very, very busy. And this is where we're sort of, I've got some copies here, if people are interested, they can take them away. But it sort of demonstrates how we're sort of moving towards developing our services. And you'll see that we've got a recovery function, which is very much around, people spend a very short time in their crisis. The rest of mental health services are very much around recovery and how we get people to that point of recovery and move them out more into the community. The other bit around that is the development of the primary care mental health services, and I'll say it later on. Around about between 85 and 90% of people with mental health problems are actually managed very well in primary care services. There are a very, very small proportion of people who are very ill that come into secondary services. So if those figures are real, which they are, we need to develop that primary care end of mental health so that GPs, health visitors, other people working in primary care have a greater understanding of mental health problems. Okay, and I'm sure that you probably will have heard the new teams that we're actually developing, which are part of the NSF. The key teams are really around the assertive outreach team, early intervention, which I understand one of my colleagues is talking about this afternoon, crisis resolution, home treatment, and primary care mental health. The assertive outreach service is for people who require intensive support in the community. And they're people that traditionally may well have actually had a hospital admission, disappeared off the scene because actually they didn't like the services we were offering, frankly, and were sort of became very ill again 6, 12 months down the road, and would actually be in the police station or in A&E very, very poorly. And some of that is around because our services were quite traditional and we were waiting for people to come to us. Assertive outreach is actually working with people in the community, in their home, or wherever they are. And if that means that our staff have to go and, go to parks, go to wherever people are, that's what they're doing. And it is intensive. People have visited, have worked with 3-4 times a day, depending on what their need is. So it's quite a lot of support. And to date, the team has had great success in actually engaging people in it. Because one of the things when you have a mental health problem is that you lose dignity. You lose so much more than that. You lose your accommodation, you lose your skills, and one of the things around accommodation that assertive outreach has proven that we've actually maintained people in housing, which has been quite difficult in the past to do that. And that really is about working very closely and working with the other agencies as well to actually. It's a 7-day service based on individual need, and I'll say that because not everybody requires a 7-day service, because that again is an assumption. So again, if somebody requires a service on a Saturday morning because they're in a particular crisis or whatever, they'll get it. But actually what we find is most people with the right support Monday to Friday and the evenings, they actually don't need that, but it's there if they do. Flexible to the needs of the users and carers, and I go back to the point around it's around the services being flexible and doing things in a different way. I think assertive outreach is set up for that. Now, I don't want to actually sort of be very Pollyanna-ish about this. This hasn't been an easy service to set up in Luton, and I think there are all sorts of reasons for that. But it's up and running now, and it's doing really well, and we've got a dedicated consultant that's really driving it forward, and a great team. And I think, well, I feel positive about it. Early intervention. I won't say too much about early intervention, because I know my colleague is speaking this afternoon, but I'll give sort of a breakdown of what it is. It's aimed at people between the ages of 14 and 35 who experience their first episode of severe sort of mental illness. And again, that really sort of, it speaks for itself really. It's actually getting in early, rather than waiting or somebody passing the buck from different agencies or whatever. Very much around getting in there, supporting people at that early, with the aim of preventing long-term need to use the services in the future. The Luton team is one of the first in the UK and has actually had a conference again, I think last month actually, to celebrate that. It's a community-orientated service, very similar in a way to assertive outreach, that it is very much around meeting the young people where the young people are, rather than asking young people to come into the teams or whatever. And again, it offers a range of interventions that are geared towards younger people, because if you actually start talking to younger people about, you know, you need a bit of therapy of this, you know, they'll quite rightly run away really. So it's actually looking at what the young people's needs are. And it goes back to individual needs. Crisis Resolution Home Treatment Service. This is a really new service. It will start in Luton on December this year. It'll take about a year to become fully operational. We've started to employ staff at this point. It's aimed to provide intensive assessment and treatment for people, particularly, and I say where appropriate, at home. One of the other assumptions that I think I always say at this point is to challenge the belief that everybody can be treated at home. Actually, they can't. It's about where appropriate, people can be offered a service at home, but it's always recognised that some people do at some stage need to be in the hospital. The other idea about crisis is that it should reduce the hospital stay, because the crisis team could pick up people at an earlier stage, really. And so that service will start in Luton. It's going to be based in Lime Trees initially, but we've got a lot of work around the States to do, so it will eventually be based with one of the acute units, so you've got that relationship. Okay, now community mental health teams traditionally have been the sort of providers of mental health services right across the system. That's what they've done for years and years and years. Well, given the fact that the NSF's been now developing all the new services, it sort of challenges us in terms of actually changing the role of CMHTs. And I put there that they are the cornerstone of mental health services, because actually they are, they still be. But they're feeling rather sort of vulnerable at the moment, because you've got these sort of exciting new teams coming up, and they're feeling, well, actually, we've been doing this for years, what's wrong with us? So it's around checking out what we're doing. And with HASCAS and myself and other people, we actually looked at how we could actually change the roles for future delivery of CMHTs. One of the elements that, again, is a directive from the NSF is that we have to have much closer working with primary care. And that sort of figures really, when I go back to earlier on, it was 90% of people, we need to be working much closer. And also, I think the role of CMHPs will be to advise and guide the staff and our colleagues in primary care as to what elements of mental health and how we can manage that. Short-term interventions. This is a fairly new thing over the last few years. Politically, we're swinging about how we can offer services. But this is for those people that have short-term crisis, that without an intervention that may be 6-12 months, they would actually would not get service until they're very, very ill, much later in this stage of illness. So it's actually getting in there, doing more preventative work. And the other element, which is going to be the greatest sort of group of people, are those people with long-term needs. Because again, the challenge, the assumption that people will not need a service for a long term is not real. So it's about managing those three different functions. Okay, primary care mental health. I've said a bit about this, so I won't sort of labour on this, but it's the local GP practices and other care professionals working in primary care and across primary and secondary care. And so approximately 90% of people with mental health are managed very well in primary care. The NSF also talks about some new types of mental health workers, which supports the primary and secondary care. We've got people called gateway workers, and these are skilled professionals who will work with colleagues in primary care in training, basically, and offering small pieces of work. Graduate workers are another new type of worker coming out of university who work with our psychology department and look at systems and processes within practices to make sure that our delivery is more aimed to those in need. And again, it's aimed to ensure that people get the most appropriate service and don't get the service that's there because that's all we've got. Well, when I was doing this, I asked myself, I said, yeah, this sounds great, But then I thought, well, how long will all this take? And as I say, realistically, it will take 2 to 3 years to do that, because there is actually a lot of cultural changes we need to make within the services. We've got a lot of attitudinal change, and that doesn't happen overnight. We've really, really got to drive that forward. And actually, this is how mental health services need to be in the future, and there's a lot of work around that. We've made really good progress to date, and that's particularly around developing the services. And Partnership Trust in April will, in a sense, I believe, will actually help us deliver this easier. We'll be much more joined up, and then I think it will help us to take that forward. And I go back to my bit, we need more user and carer involvement in the process. I've got users and carers in the development, but I need more. Okay, and I put down, I know that you've got just some contact details. Could people think of anything afterwards, or think, oh, I don't know about that, please feel free to contact me. That's where I've got email addresses, and I'll come back and answer any questions that I can do. Okay, thanks very much. Any questions?
Has anybody got any questions you'd like to ask?
Hi?
Yes, I've got a question. Before, my question is very diverse.
Sorry, can anybody hear? Can anybody hear?
My question is complex, really. It's easy to look at solutions, or treatment solutions, rather than looking at prevention, really.
Yes.
My question is that, why does people have mental illness? Something that's taken into consideration, especially people from the Caribbean, from the Mediterranean. A man or woman who works in a plantation for years, right? Being taken from there, come to this country, working into a closed environment. Of course, he's got a behavior.
Absolutely.
But it's not into consideration. He's seen as someone with a mental problem.
Absolutely. That actually is the work that around cultural training is about. It goes back to what I was saying earlier. Really, it really is about understanding the person when you actually first meet them, like where have they come from, and taking that into account in the assessment process. And it's looking at people individually and holistically. It really is around that.
Is the system doing that?
Sorry?
Is the system doing that?
The system's working towards that, very much so. I mean, we're not doing it now, we've got a long way to go, but I have to say we are really taking that on board, because very much around this whole model of care is being delivered around the needs of the service users. And it's our new teams are training in that, and we've actually got outcomes in that, how we actually challenge ourselves on how we do this.
Okay, just like to welcome those who've arrived later. It's really, really good to see you. Special welcome to Naibingi team. Well, it's always a pleasure to see you. This time I'd just like to introduce Claire Wallace from the Early Intervention team in Luton. Claire is the acting team leader. It says that she's a nurse by profession and has worked in mental health all her working life. And she started her current position in June 2003. So without more further ado, I hand you over to Claire.
Most people are probably already aware the early intervention team in Luton is very keen on promoting what it does, and it's one of the key issues at the moment is we're a new team to actually do that, so that's great for us. What Emma's asked me to talk about is something that we do a lot, and that's looking at early warning signs in psychosis, okay, and developing a plan to cope with early warning signs and how we manage those. So really, what are early warning signs? And what does that mean? In layman's terms, you think about it, if you get a cold, do you get early warning signs? What early warning signs might you get? Anybody? Sore throat, bit of a cough, runny nose. They're early warning signs. So, there's things that happen before you develop a full-blown cold. And the same thing happens for psychosis. It's based on research, and I have got some copies here if anyone's interested in actually looking at the research paper that goes with it. It's not that difficult to read, basically. Early warning signs are the first changes that occur when a psychosis is returning. It can happen quite slowly, take weeks or months before relapse actually happens, but the most frequently period is a period of less than 4 weeks, and that is based on research in this paper. Early warning signs include the changes in thinking, feeling and behaviour. And they can be fairly general things. I mean, things like difficulty sleeping, feeling a bit impatient, but they can also be totally personal to an individual. I mean, anyone can have a bit of difficulty sleeping and feeling a bit impatient, perhaps. I mean, things like thinking you might be someone else. Elvis Presley, not everyone thinks that. So why are these early warning signs important? They help to recognise the signs of relapse in the very, very early stages. And the reason we would want to know that is so that action can be taken to prevent an actual relapse actually taking place, or at the very least reduce the severity of a relapse. If early signs are recognised, then there may be decreasing in the chance of relapse, increasing in the control of the illness, increasing understanding of the illness, and also it can reduce the feelings of hopelessness. And we do this by developing what we call a relapse signature. And like your own personal signature, this is very personal to every single person. There are no two people who have two exact relapse signatures. The first thing we do is what we call a timeline exercise. So basically think of a long piece of paper with a start and the end, and significant events, external events that proceed onwards. Or we can start at when the crisis perhaps has occurred and work backwards. Okay. But things like special events, birthdays, anniversaries, things that have happened in the news. 9/11 is a really good one because everyone remembers what happens and where they were, what they were doing when 9/11 occurred. So they're the sort of things that people pick up on and remember, and they're the things we encourage them to think of. Things like just doing exams, exam times, or that sort of anything like that, birthdays, anniversaries, anything like that. And if we remember the external events, then it's a good way to remember what was happening in your behaviour, how you were feeling, and any changes in thoughts that were happening at that time. The next the next exercise we do when we developed the timeline is we do the card sort exercise. Now I have my set of cards that I use with my clients here. I mean, they're going to be available for people to have a look through. They're all based on the research. All the statements on them are what has been researched, being probably the most likely statements that people will make. And we can also help to sort the relapse or crisis developing into some sort of order, so that it has an order to it too. So what you do is record in order from when the first symptoms were noticed to the very last change. So if we're talking about an average period of 4 weeks, so you would go from 4 weeks before what happens, 3 weeks, 2 weeks, 1 week, and then crisis. And it's always, we've found that it's certainly very helpful if family, friends can be involved in this process, because quite often they'll notice something just a bit different, or they'll pick up on something a bit different. It could be really significant. When people are unwell, particularly if they're very unwell, you're not always aware of everything that's going on. And it's also important to notice that there are normal fluctuations in mood. These happen and they're very normal. I mean, say if somebody's grand dies, it's very normal to feel very sad. And you know, if you're doing your exams in school, it's very normal to feel nervous. So you've got to remember that normal things still happen, even despite somebody becoming perhaps unwell. And then once the cards have been selected, the next task is to use the timeline to help sort these cards into some kind of order and to work out the timescale in which they occur. Although we said the average is 4 weeks, it could be anything. I have people who have identified from 6 weeks before relapse. I have some people who identify only 2 weeks. It's totally personal to everybody. There's no right and wrong way of doing it at all. It's important to use that information that we've gathered. There needs to be a point to what we're doing, and so that we can get a clear plan of what to do if somebody does relapse. And what this is called is a relapse drill. Okay? And if we develop a relapse drill, it's almost like a plan, basically, of what to do when these symptoms occur. It should include a pathway to support. It should include all service interventions. Let's say one of my clients is seeing me, I would be part of their relapse plan. My involvement would be recorded as being part of that plan. And we also need to remember that lots of people have their own personal coping strategies, and these need to be incorporated into it. If you've got coping strategies already in place, we need to use them. We don't discard them at all. I've just put a few ideas up there for what sort of things could be coping strategies that we perhaps would include. Relaxation, pretty obvious one. Distraction techniques, if say someone's hearing voices, perhaps listening to music via headphones, lots of people find that sort of thing really, really useful. Anxiety management, if anxiety is an issue. Stress management, if stress is an issue, looking at what's causing you to be stressed and managing the stress the best way you can. CBT, sticking to routine is always really, really important. You know, why do you want to be changing things just when crisis and is occurring? You don't. You want to stick to what people know and what they understand and what they feel comfortable with. Seeking support, certainly involving friends and family and carers. And certainly putting off major decisions. It's very common for people when they're really unwell to suddenly start making really, really important decisions, and it's never the best time to be doing it at all. It's an important factor in that in order to prevent relapse, the support is there when it's needed. There's no point developing a relapse drill that's not going to be feasible, it's not going to be workable at all. So people need to know who to contact, how and when they can contact them, and that actually needs to be incorporated. So you would have the details of, even details they perhaps would already know, like my contact details or their GP's contact details. But you need it all written on a plan, because when things are going wrong and perhaps people are confused, these are the sort of things they forget. So it needs to be a very clear plan with very easy steps. If this is happening, this is what you do. If this is what's happening, this is what we've agreed this will happen. And it needs to include action taken by everyone who's involved in the care. So that can include carers as well, friends, family, services, whoever. So basically, this is sort of what a relapse drill would look like. So on one side of the piece of paper you would have the actual relapse signature, and you identify the statements that have been identified. I mean, the first sort of statements you perhaps would have would maybe difficulty sleeping, feeling tired, feeling a bit irritable, that sort of thing. And generally the statements that they choose, they get more concentrated as the time leads up to relapse. I mean, the whole point of developing the drill would be to actually prevent relapse from happening at all, as I've said. So perhaps if we can notice the very first signs, say 4 weeks before somebody actually develops a crisis, and we can act then to maybe put in more support if that's what's been agreed, to use some more relaxation techniques, to perhaps go to use voluntary agencies to gain more support, to perhaps even make an appointment to see the doctor. Maybe the use of extra medication would be useful for a short term. Whatever it is we've decided, we can act when the very first signs are obvious. Then we can perhaps even prevent somebody from becoming so unwell that they may need hospital admission and things like that. Also, when you write down the relapse signature, you need to identify the triggers. It could be things like a breakdown of relationships, doing exams, anything that can cause extra stress, you know, so that you may know, right, I've got my exams coming up in a couple of weeks. I know I'm going to need extra support because I find that a very stressful thing. And when I'm stressed, I'm likely to become unwell. So you can put a plan in place to actually manage all of those things. And then on perhaps the other side of the paper, you would have the relapse drill. So each of the steps that indicate the coping strategies at each stage. I've got an example. Perhaps, you know, as an example, perhaps the first thing you'll notice is low mood and lack of motivation. Feeling a bit increasingly sensitive and irritable. So step one could perhaps be setting small achievable goals for every day. Actually having it put out in each step so that you know exactly what it is you do. Talking to somebody about how you feel, making sure you let somebody know this is what's happening. And perhaps contacting your care coordinator. That could be the first steps for week 4. Okay? And then perhaps you've done all that, and sometimes you can't prevent a relapse happening. We'd like to think we could every time, but sometimes you can't. So maybe you'll lead them back on to 3 weeks prior to relapse, and then there would be another stage. Perhaps, your bizarre thoughts are increasing, fears and insecurities becoming more intense, you're having more difficulty sleeping, eating, perhaps you're not looking after your personal hygiene, and you know that's not you when you're really well. So then you would have more steps put in. Perhaps it could be something as easy as just stay calm. Perhaps you might want to challenge your thoughts about your insecurities. Maybe it'll be negotiating a temporary increase in your medication if you're taking medication and that's appropriate for you. Or it could be, talking in more depth, more input from your care coordinator, just as an example. And at each different stage, you would have different coping strategies to manage the issues that are coming up at that time. And also importantly on there, you also need to make sure you have all the contact details they may need. The contact details for the care coordinator, for the team that perhaps are looking after them, for the A&E out of hours service, for the GP out of hours service, for the emergency duty team, for their nan in Brighton, for their friend down the road. Every single person who could be a contact needs to be identified and put in with their contact number. And the time, you know, making things like A&E available to you. It is available at weekends and evenings and things like that. So that's basically it. I don't know if there's any questions, and I hope I've tried to explain it. The best way of understanding it is actually doing it. And we could do, you know, if a group of you wanted to come round, we could do a couple of group sessions just looking at picking out some cards and putting them in order and just thinking about how we can do a drill. I don't know if that is possible. If anybody would like it, I saw a few nods. That makes it. It is the easiest way of understanding it is actually doing it. It's not an easy thing to actually describe. Oh, I hope I've described something that's been useful.
Okay.
Who are Britain Managed Ethnic Groups? That's my
Sorry, I
question.
can't hear you.
Who are Britain Managed Ethnic Groups?
I'm sorry, I still can't hear you. I'm not very.
Who are Britain Managed Ethnic Group? That's the first question. My second question, are managed ethnic groups are more or less healthier than average? Are there particular problems for managed ethnic groups? What causes ethnic variation in health? Are health services able to deal with this issue? And my last question is that, is the system trying to deal with spiritual issues with materialistic and social issues?
Right, you've asked me some questions there that I wasn't quite prepared for, but I will really try and I'll give you some answers, okay? We are very keen to make sure that ethnic minorities are given the service that they deserve, but we are keen that every single person we see within our service gets a seamless service, that they all receive the same treatment, and that they all get the same service and the service that they deserve. We treat everybody as an individual, regardless of their ethnic background. And I'm sure you're aware, I don't know if you're from Luton, but Luton has a huge diversity. We culturally try to listen to them, we ask them what they want. We make sure that if there are anything culturally they want us to look at or listen to or require support for, that we will do that. We are advocates for all our service users, and that is very, very important. It's one of the key things. What was the last couple of questions? Could you give me those again? You gave me lots of...
What I call tokenistic gestures.
Okay.
So again, I'm asking these questions again. I like to see something tangible for the community. I can give you the question later on again.
Okay.
Okay?
That's absolutely fair.
Who makes up the early morning team?
Who makes up the team?
Yeah, who makes it up? You know, like what they consist of, the people who actually run it, and are there enough of them that you will actually provide the service for all the people identified?
Right, okay. Currently the team is made up, we have a consultant psychiatrist who's very much part-time. We have an associate specialist who is full-time. We have a team leader, which is myself, and I'm full-time and I'm a nurse. And the rest of the team is made up of, let me think, 4 more full-time care coordinating nurses, and we have 2 full-time care coordinating social workers currently. We do have some vacancies. We have vacancies for 2 care coordinators, and they could be social workers, nurses or OTs. OTs would be brilliant because we haven't got any.
What is an OT?
An occupational therapist who looks at occupational
abbreviations.
Okay.
I've gone through a lot of years
Okay.
and I don't understand all these abbreviations.
OT or support workers to work within the team. So we're not at full complement. We're still setting up because we are still irrelevant. That is now being addressed, and the waiting list we did have is now being greatly reduced and it's nearly gone altogether. So we do have capacity to accept more referrals into the team. And in fact, we get lots of...
Concerning the Afro-Caribbeans' mental health. I have observed, not research, and no one had come to the answer why so many Caribbeans, young men, mental, and no step had taken or researching to find out the system. I'm an old age in this community, and by observations, I observe why so many young people, mental. When we first come here, we came in a broad, open field, I put it my way. And when we arrive here, we come in a closed circuit. And the children, maybe 4 or 5 in one room. And the symptoms occurred at that time. Nobody ever researched why the young generation behave that way. Everything was clouding. And no research to say they were mental from the cradle and to up to now. A lot of idea searching for the Caribbean people. They are mental, they are misbehaving, and no step taken. You will find the majority of them, they're misbehaving because the symptoms occur at the same time they come in this country. Imagine you have 4 kids or 5 in one room, husband and wife, circle, tie them in the gutter those days, and we watch the behavior of those children, and the symptoms is there. Nobody ever developed anyway to say the Caribbean people, because of oppressions, they were oppressed in one room, and the mental occurred at that time, even at school. They show the symptoms. Neither researcher had come to it. This is the problem when they first arrived in this, through that process. And then they come back. These are the people who are the senior of the mental health to understand the needs of the Caribbeans or the mental health. You don't go by the textbooks or go into the library and to say, I found the solutions of the Caribbean mental health, the behavior. Not at all. You have to go through the community and the Caribbeans, understand the culture, understand them, then you could put a program and we'll see. That's all I have to say.
Yeah.
Do you have a question for Claire?
Okay, I have to commend you and ask you what, how many people make up, how many important people, seniority, make up the ethnic minority within your service? How many senior people are from ethnic minority groups?
It's senior, we're a team. We're all of equal standing and equal professional capabilities,
Right.
whatever.
What members?
We have, right, our consultant psychiatrist is Indian, our associate specialist is Maltese. I am English, and I think I'm actually the only full-blown English person there. Margaret is from Zimbabwe. Clive is Sri Lankan, half is Sri Lankan, half Australian. Who else am I thinking? We have Lisa, who is from Jamaica. We have Lorraine, who's Irish. We have Julia, who's a Czech Jew. We have two new people actually, Mike, who is English actually, and Chris, who is English. So, but you know, we're very much, when we employ our support workers, we're going to be requesting that we actually do recruit them from ethnic minority groups. I think that's very important. We're going to ask, you know, to make sure that we do.
I came into this county and I never knew any other West Indian children when we first came. My mother was the first guinea pig. You hear what I'm saying? After she nearly got run over and ended up in Fairfields. I went through 49 years before I even saw a social worker. I only saw a social worker when I went blind in one eye. Now, I never had no one I could talk to more than the same person who my mother spoke to. And that is my creator. When she started singing the Psalms, they used to rush her into Fairfields. This was under Dr. What's his name? The one who founded the Farringdon Wing. What was her name again?
Chester.
That's right.
I was around then, imagine.
All right. But I was out here and I didn't have no one to talk. I was being spat at by adults, even going to a football match and things like this. The chief constable, Mr. Alexander Lawson, used to have to plead for me in the magistrate's court because I used to walk with a cutlass from 9 years old. I never drew no blood on no one, but I would hit them with a slap with the flat of the cutlass. That's why Mr. Lawson used to plead with me. Right now, Mr. John Dorney, who was a historian for the whole of this area here, Dr. John Dorney, who was a historian, I used to deliver his newspapers, and with my brother, who was the first black headmaster for boys' grammar school in Great Britain, we used to sit and talk with him. Mr. Dorney was very, very instrumental for my brother so that he could teach himself to become a headmaster. He was a Bachelor of Education. He passed on this year. I myself, I was good enough to get into the armed forces, but I was never ever given license to live my life normal like another male when others used to ask me how to do things even when I was at school. I was never credited with that intelligence, and even to this day I still feel I am not credited with that intelligence. But all have intelligence. It doesn't matter whether it's an ant or what, we all have intelligence. And to her grave.
Really encouraging, asking us about what we do and what it means. We can only continue doing that. But we have no actual remit to address children younger than 14. I think, yeah, for now, exactly, yeah. The children services should have the remit for that, but we work with them as well.
So many of them will be like I, will walk for many a year, not knowing what and who they can talk.
Well, that is our aim, is to get for that not to happen.
Like I say, it's a full 14. I'm still, I could be the person who's blowing up people. I'm not doing that because of my parents and the hands of my two brothers who are in the foundation. So I can't be doing that. But we have now into life, we have people who are prepared to damage others because of what they are going through. So we've got to be very careful. One way or another, I come with word.
Before I worked in early intervention, I worked in assertive outreach for 3.5 years, which is really the other end of the scale. These are people who are chronically unwell. They're revolving door people who are constantly in and out of hospital, usually under section. And so many of my clients, when they knew I was leaving, I explained, this is what I'm going to be doing. If only something that was around when I was becoming unwell. I heard so many stories, they're relating what happened when I was 15, 16, this is what was happening to me. And nobody knew what was wrong with me. They would give me a tonic and take me to the GP. They would send me to live with my aunt because they didn't know how to cope with me. I wasn't doing well in school because I couldn't concentrate. These are all the things we want to be picking up. And these are all the things we want to be educating people about, to notice those signs and to know where they can come to get advice and help, whatever.